Hello, my name is Christian Maat. I'm a gynecologist from the Medical University in Innsbruck in Austria. And I'm really thrilled to join you today to share the first installment of the Precision Endometrial Cancer, Personalized Treatment Strategies for pMMR and dMMR Endometrial Cancer, an industry-supported symposium that was presented at the IGCS 2025 Annual Global Meeting in Cape Town, South Africa. The first segment will be presented by Dr. Alexander Olawaye. He is Director of the Gynecological Cancer Research at Meiji Women's Hospital at the University of Pittsburgh Medical Center, and he has overseen multiple clinical research projects. He is also Principal Investigator of GOG Foundation and has conducted several phase 1, 2, and 3 studies. He will be discussing the crucial role of molecular profiling in endometrial cancer. This enables a better understanding of the underlying genetics and molecular mechanism driving biology. Molecular subtyping of endometrial carcinoma is the key to personalized approaches. This is particularly important given the heterogeneity of endometrial tumors. We will learn a lot today.
Good morning again. And it's really great to have the opportunity to discuss this very popular subject with you. Those who were here for the morning session in this room would have listened to a lot of molecular talk in gynecologic cancers this morning. So it all started in 2013 with the publication of this very great article in Nature Medicine that a lot of people here are familiar with. And in that work, the Genomic Atlas Network group, they use these methods, nucleotide substitutions, microsatellite instability, and somatic copy number alterations to define endometrial cancer to the 4 popular subgroups that everybody is aware of now: the ultramutated group with pathogenic poly mutation, hypermutated group or MSH group, the copy number low or the so-called non-specific molecular profile subgroup, and then the copy number high group. These groups are, of course, very prognostic, and when they were applied to over 200 endometrial cancers, they found that the poly ultramutated group had very, very good prognosis. They're the ones on top there. And of course, the copy number high group had the worst prognosis on the MSH and non-specific molecular profile subgroup, kind of clustered together in the middle with sort of median or mid-level prognosis between those two. What is very interesting from this work is that approximately 25% of endometrial cancer that are classified morphologically as grade 3 endometrioid and 5% of the so-called low-grade endometrioid group actually have genetic phenotype that belong to the copy number high group. So these are what I like to call wolf in sheep's skin type of cancer, because they're going to behave very badly, even though the histomorphology sort of suggests otherwise. And of course, as you heard if you were here this morning, we cannot do genetic analysis on every single cancer. It's cost prohibitive and not really practical. So the surrogate to identify these molecular subgroups, immunohistochemistry is the main one, and the only one that you have to do genetic sequencing for is the poly mutation, looking for the exons in 9, 11, 13, and 14 positions, and the groups that would result from these tests are the group listed there, which we already talked about. So how do we sort of divide them up? The best thing to do is just sequence for poly mutation, and if they're not in the poly ultramutated group, go to immunohistochemistry and look whether they're MMR or D. If they're not MMR or D, look for the P53. Immunohistochemistry, P53 abnormal, we know what that does, as in copy number high surrogate and P53 Wild type will be the NSMP. And if you look at all the studies where these have been applied to prognosis, they are all in agreement that pathogenic mutation in POLE gene would result in consistently good prognosis. These patients almost never die from endometrial cancer. And of course, the P53 wild type group are in the middle. The only difference between those two is, ability to modulate this group with the available therapies, which we're going to discuss next. In general, the POLE ultramutated group would respond to IO, which is immuno-oncology, generally speaking, the checkpoint inhibitors. The MSI group, again, very good responders to checkpoint inhibitors. The copy number low group are not so clear in their efficacy to immuno-oncology, but we discussed this further. P53 wild type group, again, on clear efficacy with immuno-oncology. We do use them, especially because these cancers tend to be widely metastatic at diagnosis, and you're looking for anything that you can do to help the patients. The molecular subtype is very important, as we can see here from this extract from the Castillo study. If you look to the left-hand side of the diagram, you see that where you give chemotherapy to the P53 abnormal subgroup, you actually can modulate the prognosis, i.e. the benefit from chemotherapy because of the high-risk prognosis subgroup that they belong to. And to the right of that picture, again, you see the POLE ultramutated group. They're going to do well, whether you give them chemo or you don't give them chemo. The NSMP, the value of the treatment is not really clear, and that value of treatment is a little bit better in the MMRD group. And part of the reason why this is because the tumors which we often lump together in general clinical practice have at the molecular level are very heterogeneous. So in this very nice work by Doria, basically, if you look at the molecular subgroup, I'll refer you to the table, to the indicator below. Blue is POLE mutation, yellow is MMRD, NSMP is green, and the copy number high is red. But look at the tumors, low-grade endometrioid at the top there. Look at some of them basically are represented. The four molecular subgroups are represented, and if you look at high-grade endometrioid, grade 3, also all the four molecular subgroups are represented, just that the copy number high and NSMP are a little bit higher in proportion. The only histomorphology that has almost uniformly P53 abnormal profile is serous endometrial cancer. If you take any of the other histomorphologic subtypes, they have all the subgroups represented in them. And the prognosis of these cancers, as we said before, is affected by what kind of molecular profile they have. As you can see here, if you again have POLE ultramutation, the risk of recurrence is very, very low, and that risk of recurrence is a little bit higher in the non-specific molecular subgroup, and it's 30% as shown here, and then it goes a little higher in the MSH subgroup, and the worst, of course, molecular subgroups is the copy number high group in red there, that's 21%. And in these circular boxes, just look at the subgroup divisions that are in green is the endometrioid subgroup. Generally speaking, a lot of the cancers belong to the MSH group, which gives us the opportunity to modulate them. But if you look to the far right of that picture, you can see that even in the MSH group, some of the cancers are serous, clear cell carcinosarcoma, undifferentiated, and mixed histology. So the story from this study is that when we can, it is best to profile all of these endometrial cancers because that is going to be very relevant to treatment, especially if they are high stage at the time of diagnosis. That's not supposed to be there, but if you look at the clear cell, which we know generally has a bad prognosis, some of them actually can be poly-ultramutated. And if they are, they're going to behave in a very non-aggressive fashion with very good prognosis. Same thing with the copy number high group. They have all the histology represented there, and look to the right of that picture. You see that some endometrioid grade 1, grade 2, and grade 3 pictures are featured there, which is what the Genomic Atlas group showed in their publication of 2013. And same thing with the NSMP, with all the subgroups represented if you look at them at its morphological level. So the moral of the story is when you can profile these endometrial cancers, you should profile them because that will be relevant to what you do for the patient at clinical, under clinical situations. I'm just going to quickly transition to HER2 signaling because this is becoming relevant since we are able to target this. And generally speaking, again, HER2 signals to the RAS, RAF, the MEK pathway, and also through the PI3K and mTOR pathway, and is basically a pro-proliferation, survivor, invasion, and cell cycle progression, so that if you block this pathway, it is a very actionable target for endometrial cancer therapy. And it does matter if the expression is high or low, and A there to the far left, to the left of the picture at the top is basically negative. Expression +1 is B, and 2 is C, and high expression, which is 3+ on IHC, is what is represented in D. The R2, 3+ score with strong complete membranous staining in 30% of the tumors or more is what we call 3+. When the staining is in more than 10% of the tumors, that is 2+. That is the group that is a little confusing, that when we get that, it's good to confirm with fluorescent in situ hybridization. And one of the first studies that looked at making these actionable targets, bringing it to clinical practice, is actually Dr. Amanda Nichols-Feder and his group, where they use trastuzumab combined with chemotherapy followed by trastuzumab maintenance in serous endometrial cancer, and were able to show at the top of the picture for even in the primary metastatic setting that the trastuzumab offered progression survivor benefit, and to the top right patients with recurrent and progressive disease who were previously treated, and they benefited from trastuzumab addition if they were not previously exposed to that medication. And at the bottom is also a recurrent group with metastatic disease. And the value of this treatment was brought back into focus from the Destiny Pan-Tumor-2 trial, which basically used this very well-known ADC now, trastuzumab deruxtecan, to treat a group of cancers, and the top 3 cancers, they're gynecologic cancers, cervical, endometrial, and ovarian, and look at the response rate that they got. It was basically groundbreaking, although the number of cases in each of these subgroups was small, but the treatment was not only impressive, the duration of the treatment was very, very long. So that has become something that is extremely useful in clinical practice. But there are many different types of biomarkers. Diagnostic biomarkers used to detect the presence of cancer, prognostic biomarkers which provide information about likely disease cause, predictive biomarkers which help to determine the likelihood of response to treatment. That's the one that all of us like the most. And of course, monitoring biomarker, which is used to track response to therapy or the status of the disease. Generally speaking, molecular, the MMR status is probably the most well-known predictive biomarker. If the tumor is MMRD, it is likely to respond to immune checkpoint inhibitor therapy. As you can see here, almost doesn't matter which of the checkpoint inhibitors you use, you're going to get a good response. But if the disease is MMRP, as shown by the single agent therapies in the pMMR group below that, you can see that the response rate was very, very low. Now, in the first line immune therapy situation, we have quite a few studies which have studied immune checkpoint inhibitors in endometrial cancer, and the studies were designed differently with sort of variations in the endpoint definition and how the treatment was administered. But generally speaking, regardless of whichever one of the studies you take, the immune checkpoint inhibitor therapy was very effective, with, again, some of the lowest hazard ratios that we have ever seen, ranging from 0.28 to 0.36, all very impressive. However, if you look at the overall survival, again, some of these studies were not designed to get that, but the overall survival is, again, very impressively prolonged by the immune checkpoint inhibitor therapy in this endometrial cancer with dMMR profile. How about the pMMR group? Well, they were included in the studies, but the benefit of therapy is modest at best. In the all-comer of these studies, of course, the PFS benefit was positive, but we all know that those benefits were mainly driven by the dMMR cohort in those studies. And when you look at the overall survival from these studies from the pMMR, what I just want you to note at the bottom is that the confidence intervals cross 1 for practically all of them. And so really showing that there is no overall survival benefit in the pMMR subgroup when you use immune checkpoint inhibitors. So in conclusions, molecular profiling is critical in endometrial cancer management. Molecular mismatch repair deficiency is an established predictive marker in endometrial cancer. High expression of HER2/neu is a predictive biomarker as well. Precision therapy is expanding in endometrial cancer and should be embraced by all. Thank you.